Hello, I am here at Kenzie Dental School. I am Dr. Francis Smith, uh, uh, and my specialty is craniofacial research, and I am interviewing Professor Peter Mossey of the Kenzie Dental School. And the purpose of my interview is to inform and educate the public about the craniofacial development in the embryo and the work that we researchers do to better understand the processes of craniofacial development in the embryo and what goes wrong. And the purpose is also to look at how our research can one day help children with craniofacial anomalies and how these disorders could someday be treated and prevented. First of all, Peter, please introduce yourself to us.
Okay, Francis, my formal title is Professor of Craniofacial Development, but in effect my day-to-day work is as a consultant in orthodontics, and combined with that I also am involved in the University of Dundee orthodontic training programme at both undergraduate and postgraduate levels. And the centre that I am currently working is designated as a WHO collaborating centre, so that directs a lot of my research effort towards cleft lip and palate and craniofacial anomalies with a focus on the developing world, or a particular focus on the developing world.
Why did you become interested in craniofacial research?
Yes, in the developmental stages of my training, I was involved in, first of all, orthodontic training, but a component part of that in my registrar training in Kirkcaldy in Fife was to be on call, as orthodontists were in those days, first on call to see children that had been born with craniofacial birth defects, and in particular cleft lip and palate, because the major neonatal problem was feeding, and the dentofacial orthopedic plates were used as feeding plates. And being first on call, I was exposed to the distress that parents often had when their child was born with a cleft of the lip or palate. And my role, in addition to treating the infant with the cleft, was to counsel the parents. And at that time I was determined that if my research developed to the stage of doing a PhD, I would do that on cleft lip and palate. And in particular, I was interested in answering the question that the parents asked, is why has this happened? What are the reasons? What are the causes? And my knowledge in the field was that it was a very complex condition in terms of its etiology, but that if I got an opportunity, I would do research into the etiology of cleft lip and palate.
What is your particular focus or speciality in the field? What do you study in particular?
Well, my clinical and my research perspectives are combined in my research focus. The two major areas of interest in cleft lip and palate research are to improve the quality of care of those infants that have been born with clefts or craniofacial anomalies, and the ultimate humanitarian and scientific objective, I feel, is primary prevention. So all my third world research has a combined agenda with both quality of care and access to care in the developing world being a major issue, and my etiological research has a focus on both genetics and environmental factors, but more importantly their combination.
What do you consider your most important finding to date?
Yeah, well, over the years my research has been mainly in the human population as opposed to laboratories, although my PhD was carried out on genotype-phenotype correlation, and I believe that was an important advance to look at genotype and phenotype and how they correlated. So that early 1980s research, I was very proud of the publications that came from that. But more recently, when I looked at risk factors, both environmental and genetic risk factors, one of the coincidental findings related to pregnancy planning, and we published a paper to show how significant the reduction in risk is for planned pregnancies as opposed to unplanned pregnancies. There's still a lot of research behind that finding. That still remains largely unresolved, but it still remains for me a motivating factor to improving the environment and lifestyle and other aspects of that we can control, modifiable risk factors. And so I still consider that to be an underpinning paper of my ongoing research.
Is genetics important to your area of research, and how?
Well, as I indicated earlier, the heritability of a condition, the inheritance, the passing down of that condition is well described in the epidemiological literature. So by scanning families and their background and looking at monozygotic, that is identical twins, and non-identical twins, we can get a very good quantifiable indication in any particular disorder of the contribution of genetics. And we know that these twin studies have taught us that there is a very significant genetic component to even non-syndromic clefts, and that leaves also a very significant contribution for environmental factors. In the rarer craniofacial conditions that are syndromic, they are often a single gene defect, and the advances in molecular science and cell and molecular biology have taught us that it is now possible not only to find the genes but also to look more closely at the function of those genes. And I think that's how important genetics is in the ongoing research in craniofacial and in cleft lip and palate.
Are genetic errors important in abnormal craniofacial development?
Yes, well, the cellular research is now very well advanced in terms of looking at pathways. And when we dissect down to the cellular level, the pathways that we find mainly in syndromic cleft lip, as I alluded to earlier, those pathways to the most important candidate genes that we know are causative because of the single gene defect research, they provide tremendous insight into the biological reasons for pathways going wrong, for the elements, for example, that determine whether a cell will undergo apoptosis or transformation or any of the other signaling and expression. The key to much cellular research is finding out more about gene expression, I believe.
What else besides genetics can disrupt facial development and cause malformations?
Well, we're aware that the environment is also a significant contributor. Finding out which elements of the environment are important contributors again needs to be done at the population level and at the cellular level. So at the population level, the factors that we've found to be important are for non-syndromic clefts, maternal smoking is a very consistent risk factor. And not only maternal smoking, we have to bear in mind that the same risk is conferred by passive smoking, and therefore the environmental tobacco smoke is very significant. That means that it's not just while it's the maternal environment that's affected, the liability can easily be attributed to any environmental contributor to that, like paternal smoking or like being in a smoky environment. At the cellular level, that may translate to a problem with hypoxia. But again, the cellular and the macro population-based research need to go hand in hand for that. Other environmental factors that appear to be significant are certain nutritional factors. And we have looked at folic acid, but haven't found in non-syndromic cleft folic acid to be as significant as it is, for example, for neural tube defects. But we still believe that multivitamins do contribute. And the other aspect of the environment is maternal illness and medications that requires much more research to see how that translates again to a cellular level. Is it hypoxia? Is it some other oxidative stress mechanism? And these are factors that encourage us to continue the research.
You are mainly involved in basic research, is that correct?
Well, yes and no. I think the research I've been involved in is mainly population-based human research. But for every factor that we find to be important, either genetically or environmentally, that demands that we investigate further, and the tools that we use for that further investigation are basic science tools. So my research, I hope then will bring the basic science back into the population, i.e. make it a translational loop where basic science informs the actions that we take in the research context.
As both a practicing orthodontist and as a basic researcher, you have interaction with other clinicians treating craniofacial patients?
Yes, my experiences in the past have led me to the very firm belief that there has been insufficient interaction between clinical and non-clinical scientists in the past. I think the project that was a defining one for me happened in 2000 with an application to the European funding body. It was then called Framework 5, and along with my clinical colleagues, we applied for a package of research funding that integrated clinicians and their outcomes research with the molecular research, both in syndromic and non-syndromic clefts. In fact, the package, work package 2 of that funded research was on Treacher-Collins syndrome, because the person who led that work package was Professor Michael Dixon from the University of Manchester. And we learned so much being in the same forum, the clinicians with the basic scientists, and we did some very innovative research, and we reminded each other of the interdependence of those two research modes. And the every encounter with a patient is an opportunity for them to contribute to future research by providing a DNA sample and providing information.
How do you think research and treatment could be better integrated?
Well, in terms of integration, actual integration, we can still, even if we're coexisting in the same forum, we can ignore each other. The integration is the key factor, and the aspects of integration are closing the loop that I mentioned earlier between findings at the bench being taken back to the bedside, the translational aspects. And there are some good examples of that now, but one I'm particularly interested in, which is a little bit unconventional, is the behavioural science, where we now have more and more information on the influence of lifestyle factors and behavioural and environmental factors. But to modify behaviour is a major challenge. So there'll be a direct integration with dental public health and other behavioural scientists to ensure that when we do have good information on modifiable risk factors, we're able to modify the behaviour. And I mentioned in other disciplines such as dental caries, where we've got an entirely preventable disorder, but we still have been unsuccessful in managing that disease because we've been unsuccessful in influencing behaviour.
Okay, and other ideas would be, would you be amenable to having clinicians attending basic science research workshops and us basic scientists attending meetings and workshops on the clinical side?
Absolutely, yes, and that is an enriching experience for both parties.
Yes, it is.
Yeah. Okay.
What are the chances of prevention of craniofacial disorders?
Well, again, we've got to differentiate between the syndromic and the non-syndromic disorders to some extent because of the difference in etiology. In the non-syndromic field, there is undoubtedly scope for prevention, and we know that from the environmental contribution to the etiology. The difficulty or the challenge in that prevention is being able to much more sharply define those that will respond to prevention and those that do not. And I believe that the key to identifying those that are more amenable to prevention are being able to subphenotype, first of all, and being able to identify biochemical markers in the maternal metabolism. That's another unexplored area which I think will enable us to improve the prediction of those who respond to prevention.
And how do you think genomics and personalized medicine are impacting the field in general, as well as of your own perspective?
Yeah, well, like in the previous statement, there are cases where genetic predisposition can be detected, and GWAS has improved our ability in a very objective way to identify those hotspots in the genome where there is an association with a disease. So in this case, cleft lip and palate, for example. But what GWAS has failed to do to date is do subphenotyping. I compared this in previous dialogue to putting apples, oranges, pears and bananas all in the same category and then looking for a single causative factor. That is not going to happen easily. We must learn to differentiate with a whole range of different factors the subphenotypes. Then we'll make progress on preventing those that are preventable. Personalized medicine is exactly along the same lines, where if the risk can be detected by another route, for example, the biochemical markers in a screening sense, then identify those mothers where there is an increased risk. And I think that will come down to an individual level and to identifying the phenotype of the cleft or craniofacial disorder that is part of that family.
What do you feel are the scientific and other challenges facing us researchers for making further advances?
Yeah, well, I think there are major challenges, not just in what I mentioned earlier, the complexity. The complexity is a challenge, but that's one which we as scientists rise to. And the gene expression challenge, the transcription factors that in the past have been insufficiently investigated, the epigenetics and the gene-environment interaction. Those are all complex scientific challenges and they can be addressed. One of the other challenges in craniofacial embryogenesis research and clinical research is the lack of funding and the increased competition for funding. So we need to be aware of those large projects, interdisciplinary projects that promise to deliver real benefit. And I think we'll find that if our case is sufficiently compelling and has translational benefits and integrates with other disease groups and disease entities, then we will hopefully overcome, with the help of funding bodies in Europe and in the US and in the UK and around the world, we should be able to unlock the funds that enable us to continue those valuable research efforts.
Where do you see breakthroughs occurring in the future?
Well, the breakthroughs, if we cast our minds to what has already been achieved and translating that, there's really, as a concept, there's three ways of prevention. There's three methods of prevention. There's primary, secondary, and tertiary prevention. Now, the primary prevention, as I alluded to, is possible if we identify both the genetic and the environmental factors at an individual level, and well, that's one of the challenges. Secondary prevention has no place in congenital anomalies, so we don't need to discuss, but tertiary prevention is an area that we really have a very significant contribution to make as well, and that's through tissue bioengineering, scar-free wound healing, improving surgical skills, improving the regeneration of tissues, the integration of that with imaging. So those are areas where there is potential for breakthroughs, both in the quality of care that we provide and the normalization of the craniofacial anatomy, and also this quest for primary prevention.
At this present time, what can be done for affected children and their families?
Yeah, at the present time, we're in a situation where the repairs of the past and the techniques of the past have been shown to have some deficiency, and that's why we continue to carry out research into improving the quality of care. But for those that are stigmatized by a facial difference, then the influence of psychology and psychological support is very significant, and has now been recognized as an integral part of the craniofacial team. And I think there's much more benefits to be had in doing that, but also by raising the awareness and raising the profile of those who have facial difference and are making a tremendous contribution to society. And that ought to be much more highlighted. And I mentioned in dialogue with you about the Craniofacial Centre in Bauru in Brazil that do that tremendously effectively. So raising the esteem of these people to ensure that society is aware that they make a tremendous and can and continue to make a tremendous contribution.
I have to agree with you. Both the medical and psychological support will improve the lives of these dear children.
Yeah.
And finally, what do you foresee in terms of the awareness and detection and treatment of craniofacial anomalies in future?
I'll take these each in turn. First of all, in terms of awareness, there's undoubtedly going to be an improvement, but particularly in the developing world, where initiatives such as that by Smile Train, who have spent millions of dollars in the repair and rehabilitation of lives, that is beginning to make a significant difference to the cleft lip and palate awareness and craniofacial anomalies awareness in India. And the same in parts of Southeast Asia and in sub-Saharan Africa, and overcoming the stigmas and all the misbeliefs that accompany the occurrence of birth defects. So I do think that the Smile Train initiative, facilitated by social media, is going to make a big difference. The detection issue, well, the methods of prenatal detection I think will change. Currently, ultrasound is still the gold standard for prenatal detection, and I think that will progress to biochemical markers being much more important, and factors that can be detected in maternal bloodstream, for example. And that should make a difference to the ongoing efforts for therapies thereafter to be detected, but also to the psychological preparation that parents have when they know that there is a congenital abnormality. And then your third question was on treatment, and therapies. And I believe that bioengineering has a lot to offer. I believe that combined with cone beam CT for imaging, micro CT, 3D printers will result in improvements in the normalization of the facial and craniofacial structures by the ability to manipulate and the tissues, and the bioengineering that accompanies that will have a very significant role to play. And I do think as well that if that's combined with scar-free wound healing, then we have the ability to make sure that the entire craniofacial complex, including the soft tissues, can be manipulated to prevent relapse.
Thank you very much. I want to thank Professor Peter Mossey of University of Dundee Medical School for taking the time to speak with me today. This has been a valuable resource for us.
Thank you very much. And can I just mention one more factor that I would like you to be aware of as we develop this in the future, is just last weekend we had a European meeting to discuss a major new collaborative initiative in Europe called the European Reference Networks. And my role at that meeting was to convince the European professionals in the first instance, and the parent organisations were also represented, that there is a great deal of benefit in collaboration between centres of expertise to make this translational research a reality in the day-to-day lives of patients. So we're trying to get Europe to be much more collaborative, and the craniofacial anomalies research has very often in most countries been seen as a different entity to that of cleft lip and palate. So we're trying to get that integrated and to get scientists and clinicians to work side by side and with the parent organisations.
I have a very similar interest of my own in seeing global cooperation and collaboration between our groups of researchers as well as the clinical experts.
Yeah.
And I'm interested in further exploring the example of the Garu Craniofacial Center in Brazil.
Good. Yeah.
And once again, I want to thank you, Professor Peter Mossey, for taking the time to speak with me today on these important and pressing issues.
My pleasure. Okay, and thank you for making the long journey here.